So this is an update on hay fever in UK. There's no single accepted guidance for hay fever, so I've put together a practical approach looking at the NICE guidance from 2015 on allergic rhinitis and looking at version 7 guidance from Allergy UK. So the background of hay fever is that it's a seasonal inflammation of the respiratory tract due to pollen, and it's extremely common. About 1 in 5 people will get hay fever or hay fever symptoms at one time in their life. It usually starts at school, it's associated with asthma, and there's no doubt that poorly controlled hay fever does adversely affect asthma and increases asthma admissions. There's equally lots and lots of evidence to suggest that hay fever severely impacts performance, not just at school but in the workplace. And at this time of year in the summer, it's when children are doing their exams and it significantly reduces performance in exams. We're always asked in the surgery, aren't we, about allergy testing, and there's absolutely no evidence to suggest that allergy testing would be helpful in hay fever because it's relatively easy to identify the allergens. So the symptoms of hay fever can really be defined into 2 parts. So hay fever is triggered by an allergen triggering an allergic reaction by release of histamine from the mast cells in the cells. And the mast cells predominantly release histamine, but there are other mediators in there. And it's histamine that seems to cause the immediate effect of sneezing, itching and running of the nose, and itching of the eyes, redness and watering. The other mediators are the ones that seem to be implicated in more nasal congestion, so a blocked nose, more sinus congestion, headache and poor sleep. Aligned with hay fever is something called oral allergy syndrome, and this is a cross-reaction of pollen with foods. And this is especially with people who are allergic to tree pollen, and I'm going to talk about the different types of allergens that then result in hay fever at different points in the season. But in oral allergy syndrome, it's especially the tree pollens, and so these tend to be early on in the season. And so raw fruit, vegetables and tree nuts are the ones that seem to be implicated in this. And it can cause similar symptoms to hay fever, but more likely it's to cause itching and irritation around the throat and the mouth. And people often assume that this is a severe form of hay fever and part of an effect on the respiratory tract, but actually it isn't, it's in the mouth. So we said that we would talk about pollen, and so people get hay fever at different times in the season, and it's really important to think about this. For quite a long time in general practice, we've treated hay fever as just one illness, and we've put everybody on oral antihistamines. And it's definitely worthwhile about trying to divide hay fever sufferers up into subgroups and then treating them appropriately. So early season, February to June, is tree-based pollen usually. May to July is grass-based pollen, and then weeds, June to September, and mould at the end of the season, September, October. But mould pollen can come out if the conditions are right, and that would be if it was mild and damp. So that's the sort of rough idea over the year as how the pollen might come out. But just remember that that depending on what the sort of weather conditions are, so in 2016 we've had a very wet early part of the year, so there hasn't been a huge amount of sunshine, so a lot of the trees and a lot of the plants and a lot of the grass pollen is still in its pods. So we end up getting a week or something of some nice sunshine, and literally everything will release pollen at the same time. So suddenly we get really quite significant bouts of hay fever and hay fever connected illness, like exacerbations of asthma. So think about the weather, think about the time in the season, and obviously some people are allergic to all of the pollen types, and that can then make for if we do have some reasonable weather, that can make for really quite a long episode of hay fever. So watch the pollen count on a daily basis, and it's now commonplace, isn't it, on all of the news channels to talk about UV index on every day and also talk about the pollen count. And just remember that pollen is like fine dust. So if you think that at dawn and dusk, then as everything goes a bit quiet and there's that sort of that period of stillness in the air, then that's when this fine dust of pollen tends to settle. And so particularly avoiding contact or avoiding being outside or avoiding having your windows open during dawn and dusk when that pollen is coming down, because it then sticks on your person, sticks in your hair, sticks on your clothes, comes into the house, and then you close the windows and then it's there for the rest of the evening. Don't forget, we talked about mast cells releasing histamine and leukotrienes. Mast cells do release this horrible stuff. It's sort of almost like bleach, and so the cells get very, very easily damaged. And once the cells are damaged, they then have to be sloughed off, and hence why all of the horrible symptoms. So if you know from previous experience when your hay fever is going to start, you need to start treatment at least 2 or 3 days before that pollen is released and that bleach in the mast cells is released and starts to cause cell damage. So you're stabilizing the mast cells and you're preventing cell damage, which therefore means that the symptoms are much less. If you go onto patient.co.uk or you go onto Allergy UK, there really is quite an extensive list of things to avoid. I've put some of them here. So staying indoors as much as possible and keeping the windows shut, particularly at dawn and dusk. Avoid doing things. So if you have a grass, if you're a grass pollen person, avoiding cutting the grass, avoiding camping. And in fact, on Allergy UK, they suggest that if you are allergic, you can't avoid these things, then that you should wear an allergy respiratory mask. And if you go to the Allergy UK website, you can click on there and that will take you to accredited sites where you can buy them. Just remembering what I said about this fine dust powder. So you've been out, the children have been out at school all day, or you've been working outside. You can imagine that your clothes and your hair are covered with this fine dust pollen. So it's making sure that you think as soon as you get home to try and eradicate it. So taking your clothes off, changing your clothes for clothes that haven't got pollen on them, and wiping it off. So having a shower, or at least making sure that you wipe your face and so on. Similarly, in the summer, what do? We hang up all our washing, particularly our bedding outside. And what's that doing? That fine dust of pollen is covering all of the sheets and blankets and pillows, and then you put it on your bed, you put your children into their beds and they're covered in pollen. And so if you have a hay fever sufferer in the house, you need to think about avoiding the pollen, which is really very sticky, sticking on all of this stuff, and then you're exposing your children and your patients and adults to the pollen, which is going to trigger the reaction. So you wonder why your children are getting hay fever at night or waking you at night. That's almost certainly because their bedroom is full of pollen. Equally, if you imagine, so this fine dust is in the room already because the windows have been open during the day, just getting a fine mist spray, the sort of one that your grandma used to spray on palm trees in your living room, or tropical plants or whatever, or the sort of thing that you would spray on clothes when you're ironing them, spraying that around the room. It sticks to the pollen particles and they drop out of the air and therefore prevent being inhaled into the respiratory tract. Wearing wraparound sunglasses and just avoiding them avoiding the pollen to getting into the eyes. And some people advocate, certainly on Allergy UK, putting Vaseline or some sort of moisturising cream around the nose and mouth just to prevent that the pollen going in. Keeping car windows closed, and a lot of modern cars now have pollen filters, and the advice is that they should be changed on an annual basis at the service because they then stop to function. So you shouldn't be opening the windows, be using pollen filters. As I said back at the beginning, we need to tailor treatment to each individual. So first off, you're thinking about avoiding pollen. That's probably the most effective way of preventing hay fever. But then thinking, which pollens are you allergic to? So which part of the season do you need to be particularly careful of? And which part of the season should you be taking the treatment prior to the pollen appearing? Equally, then thinking, which are the symptoms which are worse, and treating the symptoms rather than saying to everybody take an oral antihistamine, treating the symptoms individually. And so this is a very useful table, and it gives you, looking at the number of pluses in each column, it then gives you the which treatment is best for each individual symptom, whether that be sneezing, runny nose, congestion, itching, or eye symptoms. So your top line there is intranasal corticosteroid, and there is no doubt from the evidence that intranasal corticosteroid is, as a single treatment, the best treatment for all of the symptoms. And then going down the table, there's oral antihistamines. The vast majority of people are using non-sedative antihistamines these days, although the sedative ones like Piriton are still useful, particularly in children who are irritated at night. But don't forget your child at night thinking about the bedding, thinking about spraying in the room to remove as much pollen as possible. So oral antihistamines, there are antihistamine eye drops, and they are only effective in eye symptoms. And there's intranasal antihistamines. This was a bit of a revelation to me. So azalastin is one of the few ones that's available in UK, and it's a nasal antihistamine that works really very quickly. Intranasal corticosteroid takes about 2 weeks to work. It really needs to be started before the pollen starts appearing, and then it needs to be taken for the whole time during the season or the whole way through the summer if somebody's allergic to lots of different types of pollen for it to be effective. But intranasal, very useful intranasal antihistamine, and azalastin is now also doing, it's a combination of there is now available called Dymista, which is a combination of antihistamine and intranasal corticosteroid. So might well be worth considering rather than just giving steroid. And certainly Dymista appears in the studies to work better than each individual component, but there isn't any evidence or there isn't any trials at the moment looking at the combination nasal spray, comparing it with a combination of an oral antihistamine and a intranasal corticosteroid, which is, funnily enough, the commonest treatment that we use in UK. Then we go on to the chromones, and these are your sodium chromoglycate based medications, and these specifically are in there to stabilize mast cells, and they work. The intranasal ones work reasonably well at a sort of low level across the spectrum, and eye drops, so sodium chromoglycate eye drops work pretty well for eye symptoms. I don't normally use decongestants in the treatment of hay fever, but certainly it's interesting to think if people are at that second phase, so the other mediators are affecting them, so they're getting nasal congestion, sinus congestion, then why not use an intranasal decongestant just to unblock the passages so you can get some active treatment in there. And that really was useful last year when I was looking at some of my hay fever sufferers. So in summary, intranasal corticosteroid is the most effective across the range of symptoms, but don't forget, think about which individual symptom is bothering somebody most. Intranasal corticosteroid can take about 2 or more weeks to work. If you can predict it, get the parents to put a diary date so they start their intranasal corticosteroid early. Eye drops, useful for eyes, and you can use sodium chromoglycate or antihistamine eyes. Antihistamine is useful for itch, and equally antihistamine very much for the oral crossover syndrome. So sodium chromoglycate as a mast cell stabilizer is only available in eye drop format. Don't forget to use decongestants if there's congestion, Piriton at night if there's sleep disturbance, and the antihistamine nasal spray works within 15 minutes. And so, if you give someone with severe symptoms an intranasal corticosteroid, they really aren't going to get benefit very quickly, and they might come in really quite distressed. There are some other treatments that are going around, and certainly in Allergy UK, they mention quite a lot the fact that once you've got the pollen in your nasal passages, that it's well worth using a nasal saline washout. It's not something I've ever done or tried, but it sounds pretty uncomfortable. In severe cases, so somebody perhaps going to sit their GCSEs or their A-levels, you might want to give them a short course of oral steroids. If they've got to that stage where they've had a massive allergic reaction and they really are disturbed, and sleep disturbance is going to affect their performance. You might want to get on top of it with some oral steroids for a few days while the intranasal corticosteroids and the antihistamines have a chance to work. Rather controversially, we used to use a lot of intramuscular depot steroids, something like Kenalog, and that's very much gone out of fashion, and I don't know many doctors that are prescribing it. But having said that, then in somebody who understands the risks and the benefits of taking a depot steroid, of osteoporosis and of immune system difficulties, then if somebody really, really wanted it, I think I would still consider it. In children particularly, but also adults who have this sort of allergy crossover syndrome, so hay fever and asthma, and their asthma is worse. And you may, there's been quite a lot looking at GINA, looking at the global initiative in asthma, talking about looking at people's blood count who are asthmatics and seeing if they have an eosinophilia in their normal blood count. So if they've got a raised eosinophil count and they seem to have hay fever and asthma, might well be worth using something like Montelukast, a leukotriene receptor antagonist, because that may well make a significant benefit. There is immunotherapy around, and there's subcutaneous immunotherapy and sublingual immunotherapy. And this is really the idea is desensitizing. So identifying the specific allergies in an individual and then giving them a slow increasing dose, either subcutaneous or sublingual, over a period of time, just to desensitize the immune reaction. I haven't seen this done for a little while, and certainly in some people it does stimulate just more allergy. And so you may have an allergy clinic. I think it's pretty much only done privately, but you know, in a patient that's reached the end of their tether who may be willing to look into that, you know, it's useful for you to know about it. Well, thank you for watching this short 14Fish Library module. The library itself covers all major topics that we face in surgery, like asthma and diabetes, COPD, contraception, HRT, and much more. Most of the films are a bit longer than this one, but then you can stop and start them, and you can always go back. So you know, you don't just press play and it just runs through itself. If you want any more information about the library or to see what other modules there are, just have a look below. And we look forward to getting your feedback when you start using the library, and we hope to see you soon.